very much like to welcome Dr. Abonour, who will talk about frontline therapy, the initial therapy for myeloma patients. Very, very important first step for myeloma patients. So very pleased that Dr. Abonour can be with us today to present this topic. Welcome, Rafat.
Thank you, Brian. Good afternoon and good evening, wherever you are. Thank you so much, Brian. This is an exciting time in multiple myeloma. We've been doing this for a while. We haven't seen such amazing drugs and amazing results in a long time. So it's a good time, I guess, and hopefully I'll show you some of the progress that we've made in upfront therapy. Okay. So we're going to try to move the slide. Clicking.
There you go.
Here we go. So I guess, you know, when you diagnose with multiple myeloma, what are the goals of therapy? I mean, I think two things. Obviously, you're diagnosed because you have symptoms related to the myeloma. You have bone pain, you have anemia, you have kidney failure. We're so excited about the slide here. Let's see what's going on. Let's go back to the previous slide. My clicker does not want to cooperate. Okay. Previous slide, please. Previous. Yeah, let's go here. All right, symptoms control. That's really important. So we need to, you know, get you under control quickly. And probably part of the, you know, important thing is that if you have kidney failure, high calcium, we're going to hydrate you. We're going to give you steroid. Believe me, steroids are very important in the first month or two of therapy. After that, we can ditch them. And obviously, you want to control the disease. You want to make sure that you get rid of as much myeloma as you can, and you want to minimize the toxicity. And the goal is to live as long as possible. And, you know, we need to achieve that. So I think what's evolving is that the depth of response matter. How much myeloma you get rid of is very important. In the old days, the best we could do is partial response, get rid of 50% of your myeloma. And when that happens, you know, the patient didn't live that long. You know, the median survival 20 years ago used to be 2 to 3 years. And then 10 years ago, 5 to 7 years. And now it's getting better. Why? I believe because of the depth of response. Because look at it. If you leave PR here, that's partial response on the left, what you're seeing is that it's taking not much that long to go back to where you started. But if you get rid of complete remission, it's going to take longer. But if you start getting rid of a lot of myeloma, stringent complete remission, your myeloma protein is gone, your free light chain is normal, no myeloma cells in the bone marrow, it's going to take much longer to relapse. But then what happened, that we start looking at something you heard from Dr. Brian Dury, minimal residual disease detections. We start improving on that. And when we improve on that and we get rid of the majority of minimal residual disease, you can see the curve. It takes much longer to relapse. And hopefully, when you reach these amazing minimal residual disease undetectable, your relapse may not happen for 30 years. And that means hopefully you are cured. So getting to that level of response, I think, is really very important. Okay? So for some reason,
it's working. It's working. Yeah, there's a slight delay, I think.
Yeah, there is delay. I don't know why. Anyway, so basically, what we're trying to do here is how will we detect minimal residual disease? And there are two ways to do it. But why is it important to get minimal residual disease? I think it's emerging as an important marker of lasting clinical benefit. You know, so when we look at clinical trials that have looked at minimal residual disease, patients who achieve minimal residual disease tend to have longer remission and longer survival. And we use two ways. One is flow cytometry that the IMF really sort of brought to America from Europe. The flow cytometry using 8 colors and 10 colors flow cytometry has a decent sensitivity of 1 in 100,000, and in good hands it can be even 1 in 1,000,000. And it's really nice because what the pathologists, when they're doing the flow, they're looking at actually abnormal plasma cells. And they can tell you if they have like 1 cell in a million or 10 cells in a million. And that's usually informative. And it's easy because you don't have to have your initial bone marrow to know that you have abnormal plasma cells. Abnormal plasma cells are there when you were diagnosed, when you relapse, and when you still have disease. The other more sensitive assays is the next generation sequencing. You have to have the original myeloma samples when you are diagnosed. We generate sequence specific for your disease, and then we follow you. And that's, after transplant, we can use these sequences to look at these cells and find them. And the sensitivity is usually 1 in a million. So 1 log more sensitive. So why is MRD useful? Because it's predict the outcome. Here, there are 2 data showing if the patients achieve, this is a large set of patients, if you achieve minimal residual disease negative, you're going to enjoy a better time without relapse, and you're going to enjoy a longer survival. That one on the right is looking at overall survival, and on the one on the left, that graph is looking at progression-free survival, those time without relapse. And the more sensitive the assay, the results are more actually important and reliable. Okay, so now the thing about it is that if you get minimal residual disease, it may lead you to, enjoy a very long, progression-free survival, living without the disease. And you can see on top is that even patients with high-risk disease who achieve minimal residual disease are behaving like patients what we call standard risk myeloma. So when we say you are high risk versus standard risk of what? The risk is for a short remission and short survival. And you can overcome that by getting rid of the myeloma to a level undetectable by these sensitive assay. Because if you don't have the myeloma cells around, you get rid of the high-risk clone. That's a good thing because they're not gonna, become more aggressive and cause relapse quickly. So that's very important things. Obviously, when you don't achieve that, you're going to have a sort of shorter time to relapse. So we need to sort of, work on that group of patients to try to improve their outcome. And the next slide. Basically, these are data showing effect of sort of maintenance. And this is a study that was done in France, looking at patients who had received induction treatment, high-dose chemotherapy, and autologous stem cell transplant. And if they achieve MRD negativity, they enjoy, and they had a longer time with good survival. And what means that achieving MRD negativity can save the patient taking medication, side effect related to the medications, and also cost. So this is a great thing. But so most patients with just a year of maintenance enjoy that. So again, the thing about it is that there's a great benefit of maintenance, but can be a downsides for it. And that's why, for example, some of the work that being done, and I'll show you an example of clinical trials that focus on achieving minimal residual disease that is sustained, and showed that actually that's maybe a different way of managing patients. All right. And this is just, I'm trying to make the case that minimal residual disease negativity is very important. And again, when you achieve a sustained minimal residual disease, the survival is, look at it, flat. I mean, there's nothing, better than seeing a curve that is flat. When you start seeing a drop off, when people are not doing well, either relapsing or not surviving, that's another good thing. So MRD negativity is so important for improving overall survival. All right. So you saw a similar slide, earlier, the evolution of myeloma therapy is incredible. And you can see when, a few years ago, we used to say, there are, RVD is a good thing. Revlimid, Velcade, Kyprolis, Revlimid, things like that. Now we start using, instead of 3-drug regimen, we're using 4-drug regimens. We're seeing amazing result. A lot of patients, still getting consolidation with stem cell transplant. And then the post-transplant setting, you're getting maintenance. It used to be Revlimid alone. Now Revlimid was daratumumab. And you can see the number of new therapies. So we've been around for a long time. And we used to say, okay, if we look at Revlimid, it used to be in the relapse setting. Now is up front. Revlimid and Velcade used to be in the relapse setting. Now up front. Dara used to be just in the relapse setting, is now up front. So I really think some of these drugs in the relapse setting, in the rescue setting, because we understand how well they work and because we understand their side effect profile, we're probably going to move a lot of these drugs that Dr. Osmani is going to talk about earlier on in the course of the disease. And I think that will generate better responses, more patients getting minimal residual disease undetected, and hopefully we can cure a large number of patients. So what's really important is that in the old days, we used to think about, okay, let's sequence drug. Okay, we're going to use Revlimid Dex first, and then maybe use Velcade Dex. But the most important thing is that using combination therapy. Combination therapy, that's what made the difference in the survival of patients. Just using 1 or 2 drugs is not enough. 3 drugs is great. And using 4 drugs is maybe even better, like adding daratumumab to RVD, Revlimid, Velcade. It's a great thing. So I think more to come. And, it's going to change quickly here. Okay. All right. So you heard about the trial that Dr. Brian Dury actually led and presented several times now. It's basically, we used to say Revlimid Dex is a good induction treatment for a patient not going to transplant. Can we use Velcade Revlimid Dex? Is it 3 drugs better than 2 drugs? And yeah, I mean, you saw earlier results that Dr. Brian in 101 showed you. And basically what you can see is that time to relapse and overall survival was in favor of using a 3-drug regimen. So that makes it a case, yes, we need a 3-drug regimen because we need to try to get rid of all the different clones that the patient has, because not all myeloma patients have the same, sort of correct, the baby, the myeloma cells coming from the original cells, they don't all behave the same way. So some will benefit from drug A, but not drug B, and vice versa. So the combination therapy makes a difference. So the next thing was, okay, can we add something called daratumumab, the monoclonal antibody that binds to CD38 cells, to Revlimid Dex? Would it be better than Revlimid Dex? And so this is called the Maya trial, and it was done mostly in Europe and also in North America. But these patients were not transplant eligible. They thought they're not going to be able to get transplant. So can we improve their survival? And basically, what it showed here is that there is significant improvement in the duration of response and the overall response. And a lot of patients were able to stay on therapy without having to stop treatment. So if you look at the overall response, that means how many patients responded well to the combination of Dara, Revlimid Dex, you can see it's 93% versus 81%. But if you look at the quality of the response, was much better when daratumumab added. That means you're getting more patient into complete remission, stringent complete remission. And so the initial data looks great, and the follow-up data looks even good and better. For example, if you look at complete remission and stringent complete remission was 51% versus 30% in the Revlimid arm. So clearly, combination therapy does make a difference, does lead to a better response, deeper response, and again, translate to better time without having to worry about relapse of your disease. You can see that the difference was at 60 months of follow-up, that's 5 years of follow-up, was 52 versus 28%. So a lot of patients in the Revlimid arm have relapsed, and a lot of patients in the daratumumab Revlimid arm, the combination of 3 drugs led to a better duration of response. And it does look like it translated to improvement in overall survival. More patients are alive when they get the 3-drug regimen versus 2-drug regimen. So, and they follow them for some times, and the median time to next treatment, that means, because you can judge the regimen, is that how long it took you to get into a different line of therapy. You progress because you're not responding. Was the Dara arm was only 42 months before you needed something. Not reach for the Dara arm, and for the Revlimid was 42 months. So clearly you can stay without needing a new therapy much longer when you use 3-drug regimen versus 2-drug regimen. All right. So that's, I think, an important observation. And the subsequent therapy is just based on what's available in these countries. All right, so I think the conclusion is that I think daratumumab added to Revlimid dex does improve overall survival and does improve time without disease, and it takes much longer to needing a new therapy. All right, so now we're going to go to see the patient who will probably need a transplant. And we already established that RVD, the regimen that Dr. Brian Dury studied, is a really good treatment compared to Revlimid dex. Can we make it even better? Can we add daratumumab to it, the monoclonal antibody to it? Can we make the results better? And this is a sort of phase 2 randomized study called the Griffin. Dr. Usmani and his colleagues were the leader when he was in North Carolina on this. And basically what they did is that they added daratumumab to RVD and compared it to a group of patients who got just RVD, and they give them induction, 4 cycles, consolidation was 2 cycles, with transplant in the middle between the induction and consolidation, and the patient get maintenance, Revlimid dex versus Revlimid. So, and this study's been going on for a while, so we have some mature results. So what does this mature result show? So first of all, let me show you. The Dara arm is on the left here, the kind of purplish color, and the orangish color is on the right, is the just Revlimid, Velcade, dexamethasone. And what you can see is that with each step, the number of patients getting stringent complete remission is increasing, and after 1 year, it reached 63%, and at 2 years, 66%. In the RVD arm, that stringent complete remission is lower. So this regimen, adding now daratumumab to RVD, 4-drug regimen, is inducing more responses that are deep quality responses. And this is the result of minimal residual disease testing. We talked about earlier, that MRD negativity is very important. And what you can see here is that getting MRD negativity increased with each step in the Dara arm from 22% to 64%. In the Revlimid arm, went from 80 to 30%. So twice as many patients after 2 years of therapy are achieving minimal residual disease. That's unheard of. So I think it makes sense that the 4-drug regimen are producing deeper response to a level that undetectable in the bone marrow. All right.
Okay.
I have to figure out my clicker here. And you can see the time to MRD negativity is faster in the Dara Revlimid arm, and you can see larger number of patients achieve that, while the people who just get Revlimid dex was, they get there, but not as high, the percentage, and not as fast. So basically, the median duration to MRD negativity was 8.5 months in a DARA RVD and took 34 months for the Revlimid Velcade Dex to get there. So you get there, you get to MRD negativity faster, and more patient gets that. Okay.
All right.
I may have done something to my, and obviously the progression-free survival based on intention to treat was also in favor of the patient who get DARA RVD. You can see almost a flat line. The majority of the patients have sustained a sort of lasting remission. So that's what we want. We want to get more patient getting MRD negative and more patient have a sustained control of their disease. We don't want a patient start relapsing in a year or two. The longer, the better. All right. So the second thing is that I think that is really exciting is this approach by Dr. Luciano Costa from Alabama. A very, he recruited other academic centers and came up with this trial called the MASTER trial. And I start calling him Master Luciano because I think it's really a beautiful way of looking at how we should be treating multiple myeloma. And basically what he did is that, all right, we know that 4-drug regimen is good, and we believe that carfilzomib is a very good PI. So can we use daratumumab, carfilzomib, lenalidomide, and dexamethasone combination in a way that will use it for induction followed by transplant, and then get guided by MRD negativity to decide what we're going to do next. Okay? So what did he do? What did he do? Basically, what he did is 4 cycles of induction with these 4-drug regimen, DARA, carfilzomib, lenalidomide, dexamethasone, followed by autologous stem cell transplant. He did check MRD after each sort of, step, but didn't make a decision what to do until after transplant. And if you got MRD assure or MRD sure, that means, you get tested twice, you're MRD negative, we're going to just watch you. But if you still have MRD positive cells, minimal residual disease still detected in the bone marrow, he gave another consolidation, 4 cycles, and then decided he's going to do 4 more cycles of induction. And if they are MRD negative, we're going to call it a day. But if you still have disease, you're going to get lenalidomide maintenance. So what happened? So let's see what happened. So first of all, if you look at all patients, by sensitive next generation sequencing assay, he's getting a lot of patients who achieve MRD negativity. And when he looked at patients who are, and used several, the top is the flow, the red, and the blue is the next generation sequencing. And what he showed is that you're getting really large number of patients getting MRD negativity. And if you look at patients who have no high-risk cytogenetic or one high-risk cytogenetic like 17p deletion, the response is still really good. The patients who do not achieve such good results are the patients who have what we call double hit myeloma. That means there are 2 different kind of high-risk features present. And so if you look at the patients who, in terms of progression-free survival, the patients who have one high-risk cytogenetic or none, actually looks like majority of them stayed without progression with now follow-up of a couple years or more, but the people who have high risk still not enjoying the same duration of disease-free survival. And the overall survival looks better for the patients who have standard risk myeloma or one high risk cytogenetic. So the majority of the patients are benefiting from such approach that is MRD directed, go or no go based on where you are after you get your induction and transplant. So this is an opportunity for us to say, does everybody need maintenance? Does everybody need consolidation? I think it's generating a lot of questions that ought to be tested in bigger trial, and I think there's a lot of interest in those kind of trials, and a lot of cooperative group are testing that. So I think, you know, the conclusion from the master trial is that next generation sequence response adaptive therapy is feasible in the majority of the patients and in the multi-center, and 72% of the patients enrolled on this trial achieve what we call MRD sure. And patients with standard high-risk cytogenetic have similar depth of response and low-risk MRD. So I think this is a good group that if you have one high-risk cytogenetic, you're going to do good. And that's, you know, that's an improvement because we used to think that these patients are going to relapse in a year or two. So I think quadruplet therapy, achieving MRD negative, will able to explore this concept. Where we still struggling, I think, is the ultra high risk. You know, when you have, for example, you know, gain of 1q and 17p deletion or a p deletion, or, you know, some of the translocation 414 and things like, I mean, the 614 and like that. So I think it's a really amazing trial. So, you know, we don't have really time to talk about all the trials that have been going on, but I'm trying to give you a flavor of some of the other things that are going on. For example, this is going on in Germany, where they added isatuximab, is the other anti-CD38 antibody, to the RVD regimen in the newly diagnosed patients. So what did the Germans show? So basically randomize them, you know, a large number of patients to induction, stem cell transplant, and then maintenance either with Revlimid alone or with Revlimid and the antibody isatuximab. And the goal is to see how many patients will achieve minimal residual disease. And you can see that by next generation sequence flow, which is, you know, detecting 1 cells in 100,000 cells, what you can see is that when you use the 4-drug regimen, a monoclonal antibody with RVD, you're getting more patients enjoying a better overall response rate. And with each step, the number of patients achieving complete remission is increasing. And you see in when you add an antibody, there are more patients achieving very good partial response, more patients achieve a stringent complete remission. So it is, again, another trial showing that 4-drug regimen improve overall response rate and improve the depth of response. And this is just sort of breakdown of some of the side effects that we're seeing. And obviously, when you add more drugs, you're going to see more side effects. Some of it is related to drop in the blood count. Some of it related to infection. For example, in the 4-drug regimen, you're going to see, you know, more, for example, infection 43 versus 34%. But, you know, I think we are aware that, you know, this is happening and we can manage those things safely. Okay. Where are we next? So I really think, I mean, you know, the upfront therapy is evolving. And, you know, I didn't say, you know, I mentioned to you trials that was testing 3 drugs in transplant eligible patients. I show you trials that testing 4 drugs in transplant eligible patients, where the induction is 4-drug regimen and followed by transplant. And basically what I'm showing you here is that right now, I think commonly used in the US for patients who are going through transplant, at least a 4-drug regimen. You add a monoclonal antibody against CD38 to VRD or KRD, and we think is feasible with limited toxicity. You're getting deeper response, and you're getting more patient achieving minimal residual disease, negative disease. And I think MRD becoming an important measures that we probably start to include it in our assessment of how well our patient doing, and use it, maybe to escalate, de-escalate the therapy, and guide us, where to go with high-risk disease. That's still, a challenge, but it seems like maybe not your typical high risk. The ultra high risk continue to be a group of patients that need more attentions, more clinical trials to try to answer the question. And I didn't spend a lot of time about transplant. Is it important? I think if you look at all of the study that's showing much deeper response, more MRD negativity, better overall survival, has really included transplant. High-dose melphalan still play a role until we have better trials in the era of better induction treatments and better monitoring. Still has a room for it. So we still recommend it to our patients who are eligible. The question is that, will we replace it one day with something else? We don't know. We don't have the data yet, so we still include it. I think that may be my last slide. Let me see. Okay, so let me just go to one more, sort of futuristic trial that is called the MASTER-2, and it's just address what I was saying earlier here in the last slide. Is that, can we now say, okay, what he did is that he used consolidation when he doesn't get MRD negative after the induction and transplant. Well, you're going to hear from Dr. Osmani about the bispecific and the CAR T cells, and he's going to tell you how we're able now to manage the side effect. How can we control cytokine release syndrome and neurotoxicity? They would becoming familiar with these side effects. We can manage them, and we can probably bring those therapy early on. Why should we wait until the patient has a horrible myeloma that we cannot control? So if we have a high-risk patients, double hit myeloma, we're not getting MRD negativity, we can consider some of these, new therapy, because you're going to hear about the mechanisms of action. They're totally different than the drug we use up front. If you're going to keep using the same image, the same monoclonal antibody, you're just not changing anything. You're not changing the biology. But when you use the T cell specific, bispecific engager, for example, what you're doing here is that you're making the immune cells work in your favor. You're trying to get your myeloma cells to be recognized by the T cells. You're making the T cells angry, get rid of the myeloma cells, and hopefully get rid of all the ugly cells that left behind, and the patient then will achieve a sustained MRD negativity and perhaps cured. Why not? All right, I think I am here toward the end. I have to figure out why. Okay, so you better watch it, myeloma. So we're going to take care of you. And so there are 3 myeloma patients here and one guy trying to pretend that he's a cyclist. So, but we're going to take care of myeloma. I think it's really exciting time. Some of the drug you hear from Dr. Osmani, I really think they should be used early on. And we start thinking about myeloma as history, not as a continuum that we have to deal with all the time. With that, I'm done.
All right. So thank you so much, Rafat. And a number of questions have been coming in, and most of them you've touched on and made it clear that they are actually still questions. One question is about high risk. Were high risk patients included in the Griffin study? And then obviously the MASTER trial really evaluated high risk with the finding that the ultra high risk really still need extra attention. So maybe you and Saad might want to comment on the current status of high risk. I think earlier you mentioned, Saad, that there were 7 trials for high risk going on. Somebody wanted to know, well, where are those 7 trials?
So, I'd mentioned that, that there have been 7 trials that have been reported. And there are others that are actively being planned, and we will have 3 frontline high-risk studies open in the United States by early part of next year. One is going to be a cellular therapy-based concept or clinical trial where we're going to use CAR-Ts in earlier lines. There's another one which will incorporate bispecific antibodies, and then there's a third like a consortium platform study, which will be exploring, different questions, whether we need to change something in induction, whether we need to change something in consolidation. Right. So I think those are coming. So there's a lot of hope for high-risk patients, but some of the newer therapies that I'll talk about for relapse patients, we are going to be moving them up for high-risk patients soon.
Yeah. Maybe you can just touch on that as you go through a variety of those new therapies in a moment. Yeah. Rafat, any other comments? I mean, the 2 comments really are the role for autologous stem cell transplant, and basically you've said that we're still doing that for the time being. Because it prolongs remission. There was a question actually, which was indicating that maybe the high-dose melphalan increases genomic damage, which is something that one of our colleagues, Dr. Richardson, frequently talks about. I don't know if there are real pros and cons to doing the stem cell transplant, but you're still recommending it, right?
Yeah, I would still recommend it. Obviously, some of the data, on the genomic instability is probably related to, having cells to become genomically unstable. Getting rid of it to a minimal residual disease undetected, you're not going to worry about genomic instability. So if you look at all the trials that really have a high level of MRD negativity, included induction with 4-drug regimen, followed by transplant, and maybe some consolidation or maintenance. And that's when you're not going to see that, So I really think, there's, it's not totally wrong to say that there's genomic instability. What I really think is wrong is to think about myeloma as a disease that we're going to be able to deal with continuous therapy. That also will generate genomic instability. Having myeloma cells around, they're not going to be behaving. I always say that, when you live in a bad neighborhood, you're going to become bad, So that's, you want to get rid of these cells, So that's why I sort of like the idea that, if it's feasible with a limited duration of treatment to get MRD negativity, why not? What do you think, Saad?
Yeah, no, I agree with you. I think, there are 2 important things, and when we listen to other experts, it's very important. People say things in passing. So I want to be very specific about the data. So, what we comment on is this observation that actually came from the Memorial Sloan Kettering data set, actually. It was a paper that was published by, us in collaboration with, the Arkansas group, some European colleagues, and with Ola and Francesco Mora in Miami now. And the observation is that high-dose melphalan increases the gene mutations in myeloma cells, but there is no data to suggest that that's a bad thing. Why? Mm-hmm. Because the PFS is always better on the transplant arms. and the issue is that, transplant has set such a high bar of progression-free survival. It's going to be very, it's a high bar, and we'll have to beat it with frontline studies, which we do not have now. So, until then, we have to follow the data because, if anything, one can actually, argue the other case that if you have more, genomic instability, you actually create more neoantigens that the immune system can take those cancer cells out better. So I think, that there are a few different ways in which we can look at that data. But I support what Dr. Abonour was saying.
All right, right. Great. I'm going to touch on, there's a couple of questions. Why is MRD status not standardized? Well, I think that the definition of MRD negative is standardized in that we have 10 to the minus 5 as the cutoff. You're not supposed to be MRD negative unless you're at least 10 to the minus 5. But what I would say is the reporting of it is all across the board, 10 to the minus 4, 10 to the minus 5, 10 to the minus 6. And so 10 to the minus 6 is obviously better in terms of outcome versus 10 to the minus 5. But really, we should not be reporting MRD negative unless one has achieved at least 10 to the minus 5, either by NGF or by NGS. Then a question about the timing. I think that the best timing for doing MRD testing is still a little bit up in the air. However, one question and some of the data you saw is that with ongoing therapy, response deepens. And so about 10 to 15% of patients will achieve their best level of MRD negative after or during the maintenance period. And so actually, overall, one of the best times to do an MRD test is after about 12 months of treatment, where the maximum number of patients will have had an opportunity to achieve MRD negative if they're going to do that. In a relapse setting, it's probably a good idea to test the MRD a little bit sooner, more in the 6 to 9 month time frame. So that maybe covers some of the things. What is PFS? Yeah, some of these basic questions. What is PFS? Progression-free survival. This is basically the time that a patient stays in remission without the myeloma progressing. So progression-free survival. How do we know for high risk? That is based on either the FISH testing, which shows those problems with chromosome 17, chromosome number 1, 414, things like that, or if relapse has occurred in that 1 year time frame, or if some other things have happened like plasma cell leukemia with myeloma in the blood or myeloma in soft tissue areas, what we call extramedullary myeloma.